And Matt Anderson, who always starts his presentation by thanking me so much because he was the first speaker. You don't have to do it today, Matt, but I will tell you this is the 100th session since you started this. Thank you. So without further ado, I'll turn it over to Matt Anderson and Danielle Martin.
Great. Thanks, Anton. Thank you very much. Thrilled to be number 1 and number 100. That's a nice bookend. Thank you for the opportunity. I just wanted to start with introducing Danielle Martin. Little story about myself and Danielle. We just got to know one another when Anton thrust us together. One of the things that was really great and hopefully becomes evident as we go through this presentation this morning is that this was my first time spending some time with a primary care doc talking about how the system should evolve and what opportunities we have. And I was thrilled to find out that we actually didn't argue all that much.
No, not much.
We were pretty much on
Not
side.
yet.
Not yet, that's right. So we'll see if we can make it all the way through the next hour not arguing either. But perhaps instructive for our time this morning is that hospital CEO, formerly at the Toronto Central LHIN, sitting down with a primary care physician, talking about some of the big issues that we're facing in terms of integration of our healthcare system. And to my pleasant surprise, we were pretty much on side on many of the big issues. And maybe that's something we can take away as we go through our presentation this morning. Does that work? Which way would I point? Ta-da. And just for the record, that was a doctor showing a former CIO how to use the clicker. So thank you. I thought I would point that out before Matthew Morgan does in the question and answer session later. Thank you, Matt. For Danielle and I, we thought we would start with, hopefully everybody has seen this. This is the Ontario Action Plan for Healthcare. The minister introduced this document probably about 8 weeks ago at a lunch session here in Toronto. And it has some pretty remarkable things. If you're not familiar with it, I really do encourage you to take a look at it. It's a short document, but a pretty powerful one, talking about changes that they want to have in the healthcare system. And a couple of things that Danielle and I are going to focus on this morning really are around family health care. And how primary care is going to focus into the LHINs. We've got a couple of quotes for you on the screen there. I also wanted to read a little passage for you, just a couple of sentences. So there's a section here that it's entitled Family Health Care at the Center of the System. Family care providers are a natural anchor for patients in our healthcare system. They are well positioned to help patients navigate the system, particularly patients with multiple complex conditions. So this is a statement, again, that might surprise some to hear that as the head of a hospital-based system, I completely agree with, and is really the backbone of what Danielle and I are going to talk about today. The challenge for us is to figure out, how do you actually do that? What does it mean to put doctors in the center of the system? And as we go through this, what we thought we would do is try to keep in front of us what really are the objectives that we're trying to achieve in the healthcare system. And there were three, and these can be worded many different ways and can be presented in different forms. But we felt that these were three statements that seem to be true in this document and seem to run well throughout many of the other documents that have come out on healthcare change. So a focus on outcomes, which you're going to hear quite a bit about, a focus on efficiency, and the opportunity to improve the patient experience. And I think, Danielle, it's here where we really found the backbone of what we're trying to do moving forward.
So we're not going to spend a lot of time making the case for integrating family health care or primary care and acute care, because I think in all likelihood everyone in this room has already been sold on the benefits. If you take your average individual who faces a risk of ill health in the future, like our gentleman on the screen here who's overweight, has diabetes, we can see two potential paths for this person. One is that he gets well managed in the community, empowered to manage his own chronic disease, gets the care that he needs in a timely way, integrated across the system, and manages to live a long, healthy, productive life. The other is that he becomes a frequent flyer in emergency departments, like one of the 10,000 people last year at Osler who came into the emergency room with diabetes-associated complications as their primary concern. Costs a lot of money to the healthcare system, ends up getting a bunch of complications, and doesn't achieve what he's capable of achieving, both health-wise and as a member of society. So obviously, the purpose of integrating the primary care system and the hospital acute care system, as well as other community services, is to try to lead that individual on the upward path. The question is, how are we going to do it?
And just as we sort of head into that, one of the things that we wanted to acknowledge is that, first off, this isn't a new idea, the idea of integrating the healthcare system. And we're kind of pleased that there's a whole bunch of papers and positions that have come out, and we've just selected a few logos, and we don't mean to offend anybody if we didn't put your logo on here, but these are just some of the associations and groups who recently have come out talking about the need to integrate primary care into our healthcare system. Just a couple to pick on. I've already talked about the Ontario Action Plan. The little symbol on the side here, the Commission for Reform, that's the Drummond report. And certainly there were a number of recommendations made in Drummond around the integration of the system. The OACCAC and the OHA, and I don't think we have the Canadian Mental Health Association logo up there, but they recently, about a year ago, produced a paper called Bending the Cost Curve, again focusing on this notion of how do we better integrate our healthcare system. So for Danielle and I, we can honestly say this is not just sort of our idea. These are ideas that have been put forward moving forward.
So I guess just before we move on, though, one of the things that we talked about in preparing for this presentation is how deep do we really think this agreement goes? I mean, we see a whole lot of position papers being put out by a whole lot of organizations who say integration is good. But obviously, if everybody agreed, probably we would have a more integrated system already. So where are the points of resistance? Who's got something to lose here? What are the interests, right? Who's got the most to gain? And I think that one of the questions that we need to ask ourselves going forward is how deep is this so-called consensus that we seem to see emerging?
And I had told Danielle beforehand that we're not to do anything controversial at this meeting. At the end of this meeting, she can go back to being a doctor if things don't work out so well. I have to go back and run a hospital, so be very careful where we go with that. I would agree, though, and what I think all of the papers have done is they've sort of outlined that this integration is important. Again, as Danielle has already mentioned, we're not really here to debate whether integration will in fact, or what are the merits of it. We're here to say, okay, so we've all agreed at a certain level that integration of our system is going to be important. So far, we haven't really gone down into how exactly are we going to do that. So this morning, we're going to take a crack at how would we integrate primary care into our local healthcare system. A couple of points to note that we focused on as we tried to put this together. First is we recognize that whatever solution we have to put in place does not cost the system more money. And we are all aware of why that would be. We were looking at a structure that builds a culture of local empowerment and professional respect. Aligns with existing provincial framework and quality improvement. And we'll put that out a little bit more as we go through some of our slides. But we are trying to work within the frameworks that we have. We'll talk about Health Quality Ontario and other, the ECFA legislation. In fact, our treatise is that we probably have all of the organizations, legislations, and structures that we need. How do we pull that together? We need to allow for localization, which we'll talk a little bit about, and a focus on on-the-ground improvements. I'm going to hand it over to Danielle in a moment, but before we do, just a couple of caveats that we want to put out there. These would be, again, the caveats from those of us who aren't doctors and can't go back to being a doctor. Just want to make sure everybody understands the conditions upon our recommendations. First is that, as we've talked about, we're not spending too much time on is integration the right way to go. We believe that it is, but the details of that have been articulated by others, and we'll leave it with that. We're also going to spend most of our time talking about hospital and primary care integration, as you'll see in our examples. That is not in any way to suggest that you can achieve full integration of the system without the other players. We certainly need the CCAC involved, community health agencies, CSS agencies. We're keeping our comments for this morning just primarily around acute care and primary care. And finally, both Danielle and I have been party to some discussions that we've had with others on this topic. So not every idea up here is going to be new or exclusively ours, but we're hoping that we're going to be able to put it together in a way that's a bit unique for this morning.
So let's set a little bit of context then. In Ontario, we have now almost 12,000 family doctors going to work every day seeing patients. And amazingly, and I have to say, as someone who's been heavily involved in health policy discussions, particularly in the area of primary care, I was shocked by this statistic. I don't know how many people in this room realize that more than 2/3 of Ontario's family doctors are now off fee-for-service as their primary model of remuneration. That is a massive transition over the span of the last decade, and it has real implications in terms of our ability to integrate between primary care and hospitals. So, you know, you've got about 20% of family doctors who are either doing some kind of a focused practice, so not really doing comprehensive family medicine, or practicing part-time. You've got 1,500 fee-for-service family docs, and everybody else is on one of the F words, the FIGs, the FINs, the FOs, the FITs, which means that they're practicing on some combination of capitation, or in some cases, in the case, for example, of community health centers, on salary. So that's, you know, what the lay of the land is in terms of family medicine. So just to be clear, this means that we essentially have 700 primary care organizations operating in the province of Ontario. So when you want to talk about integration, you're talking one at a time, 700 independent practitioner groups, all, you know, out there serving clients, serving patients in the way that they feel works best in their local environment. And what does that break down into? Well, we've got nearly 200 family health teams which are providing care for about 20% of Ontarians, and then you've got CHCs, AHCs, nurse practitioner-led clinics, of which there are a few, and all kinds of other models. All of these, you know, working side by side. Now, I know that many of you will have read the ISIS report, Therese's work that just came out last week or the week before, looking at the variation of demographics of patients that are in each of these models. And they also looked at emergency care services and the variation in accessing emergency care services across these. I think the point that's important to take home is there's an enormous diversity of models. There's an enormous diversity of payment models, and those models are serving different kinds of populations, and many of them exist side by side in the same LHIN or in the same hospital catchment area. So any plan for integration is going to have to take into account that wide or wild diversity. So how integrated it is today? Well, you know, I have to confess that when I saw this, this graph from the HQO 2011 report, I laughed. Because, you know, they put Canada sort of in the middle, or rather Ontario in the middle in terms of percentage of adults who report that their family physician seems informed about the care they received in hospital, including any new prescription medications. And I must say, I think that is a wildly optimistic vote on the part of our patients. You know, I thank them all very much. But just because I nod sagely when you say I went to the emergency room and they told me I had pneumonia and put me on this antibiotic, you know, that may mean that I've heard of pneumonia. It may mean that I know where the emergency department is. I can assure you that it does not mean that I was aware that you were in the hospital. It does not mean that I was aware when you were discharged. It does not mean that I have any clue what the plan for follow-up in your care is supposed to be. And so, you know, I said to Matt that I wanted to be able to tell a few stories today, and I know that there's a fine line between anecdote and illustration. I'll try to stay on the illustration side of that line. But I've just in the last couple of weeks been in a fairly heavy interaction with a local hospital that's 2 blocks from my office. It shall remain unnamed. A 43-year-old patient of mine died in that hospital in early February. And I found out 3 weeks later when my office called her house to book a specialist appointment for her and got her mother on the phone and said, well, hadn't you heard? And no, I hadn't heard. I hadn't heard that she'd been admitted. I certainly hadn't heard that she had passed away. Although my name was on her chart as her family doctor, and the hospital is located 2 blocks from my office. And in fact, I practice in a hospital. I'm in an academic family health team, and my own hospital requires patients to fill out a consent to release information if they go to the emergency department of my hospital in order for me to get the information about their emergency department visit. And so we are dealing in, I mean, this 68%, I have to tell you, if you were to survey family doctors, I think you would get a number that is substantially close to zero. Now, what are the I'm going to depress you all, and then hopefully Matt will lift you up into the world of hope and optimism. So, what do people talk about as the preconditions to integration? People spend a lot of time talking about the EMR, right? And how it's important that we have shared systems that can talk to each other. And I have to say, I mean, I work on an EMR. I love the EMR. I think it's a fantastic thing for patient safety, for quality of care. But in no way is an EMR necessary for system integration. So all those people out here working in eHealth can breathe a sigh of relief. We're not waiting for you guys to integrate primary care into the rest of the healthcare system. And the example I like to use on this is there's a community-based pediatrician in Toronto who I sometimes refer my pediatric patients to when I need a consultation. And when they go to see him, within an hour of their leaving his office, I get a fax back from him, one piece of paper, about 5 words on it usually, the kid's name, his 2-word diagnosis, and his 2-word treatment plan. And 3 weeks later, I get a proper dictated letter with all of the details, but all I need is those 5 words, because when the mom calls me the next day to say, we saw Dr. So-and-so, I'm not so sure, or can you explain, or do you understand, I have that information. So it doesn't have to be fancy. It's just about providers talking to each other and each of us being able to put ourselves in the other's shoes.
So I'm really glad that I changed jobs, because I used to be a CIO. And so apparently it's better that I'm a hospital CEO now, because I can stay employed and still work on a few projects. And one of the projects, I was allowed to do a good example of some integration. And I would have to back up Danielle on this point. We have a project going on right now at William Osler, which we have called Bridging the Gap. Our Chief of Family Medicine, Frank Martino, if you happen to know him, he's a very flamboyant guy, and he comes up with really cool terms. So Bridging the Gap. And what we're doing, we're relying on this very old technology called the telephone. I'm not sure how many people are familiar with it, and it's actually connected to a wire into the wall. It's really quite old technology for sure. And what we're doing, to Danielle's point, is pretty basic. We have a project where when a patient is admitted into our hospital, our hospitalists will phone the family doc and collect any information, let them know the patient has been admitted, and ask, is there any information that the hospitalist should know about, given that this patient is now on the floor. The second part of it is that we make a phone call. Our hospitalist will phone the family doc on discharge to let the family doc know that the patient is being discharged. Here's the meds that they're on. Here's any particular conditions that they should be aware of. And also to have a quick discussion on, does this patient need an immediate follow-up appointment, or can it wait for a few weeks? A couple of interesting things about this. First is that we're finding that the admission phone call is not particularly useful. Perhaps challenging the concept, certainly a concept that I've always thought was true, was that the family and the patient are not able to relay accurately information to the hospitalist when they're coming into the hospital. Important information is being missed when the patient comes into hospital. What we've been finding, we've been running this for about 6 months now, and what the hospitalists are finding is that the patient and family are actually pretty good at letting them know what are the conditions that the patient has. So that phone call hasn't proven all that valuable, and we may in fact get rid of that phone call from this process. We have found that the discharge phone call has been quite useful. One of our challenges, however, is that we have, as many of you would know, William Osler has sites both in Toronto and in the city of Brampton. In Toronto, where there are multiple other hospitals, meaning that for a family care doc, their patients could go to a whole series of hospitals. We're having trouble getting some traction on the project because for a family care doc there, you're talking about maybe 10% of their patients would actually end up over at the Etobicoke General. So just the logistics of trying to schedule phone calls and all that kind of stuff, the value gets diminished a bit. Whereas up in Brampton, where we have we've cornered the market, where about 80 to 90% of your patients, if you're a family doc, if they're going to hospital, they're going to the Brampton Civic Hospital. It becomes a lot easier to engage on that because we're now talking about a pretty big part of your practice. So we are starting to see some improvements. We are using low tech. I would say, however, that we are starting to branch out with a few docs who want to share our record, because we do have the record there, and it is shareable, and we're starting to see a few docs who are interested in doing that. But it has been great, just that phone call and saying, hey, how do we make that connection from hospital care to primary care?
So, of course, for every good news story, there's also a bad news story. And it's clear that these examples of good integration, which do exist in the system, have not been scaled up. And, of course, this is always the challenge in Canadian healthcare is the pilot project syndrome. So how do we move from a world of really cool examples to actually a system where integration becomes the norm? And sadly today, absence of integration and in fact, barriers in the way of integration continues to be the norm. So anyone who's ever worked in a hospital knows that it is much easier when a patient comes in to simply order repeats of all the tests that have ever been done on that patient than to try to track down the results of the ones that have been done previously or recently. And one of the things, although it may be true that patients are, and of course it's true that patients are good at telling their stories when they come into hospital, what they may not be able to relay to healthcare providers, what I would submit they're not necessarily able to relay to healthcare providers, is what's been done already. And so there's a massive amount of duplication that occurs when patients are admitted to hospital in the system, and that leads to unnecessary radiation, unnecessary testing, and huge costs to the system that could be avoided. The other thing that they may not be able to relay to healthcare providers is the things that have been tried already but didn't work. And so I frequently have patients who come back to me and say, well, the doctor in the hospital said to me, how come your family doctor didn't put you on such and such a drug? And I'll say, well, actually, we did put you on that drug, you may recall, 3 years ago, but you had a cough from it, or it gave you a rash, or you didn't, it was too expensive or whatever, so that's why we ended up moving you to this. So there's a lot of that kind of history on the investigation and treatment side gets lost in translation, with the effect of duplicating a whole lot of things when a patient comes into hospital. And on the primary care side, when the patient comes back, there are often changes that are made to the management in hospital that we're not able to continue because we're not aware that they occurred. So I recently had a patient who got sent to the hospital actually from my clinic in massive liver failure, and she came back to see me a couple of weeks later, and I said, so what did they tell you was happening? Why were you there for 2 weeks? And she said, I had a bladder infection. And I thought, boy, my anatomy's not that great, but I'm pretty sure the bladder and the liver are fairly far apart. So, it took us about 45 minutes of, getting into, and there are some shared electronic systems, so I was able to pull up her ultrasounds and her CT scans and all this kind of stuff, figured out that what she had actually had was a gallbladder infection, which made a lot more sense to me. But of course, by that point, I've got, I'm an hour backlogged, and there's 20 patients sitting in my waiting room looking really irritated and wondering why it is that I'm never able to stay on time. And so a lot of this stuff, I think, is avoidable, but we need to figure out some way to break down those barriers.
Right. So where do we go from here? And Matt and Danielle's theory on what steps do we need to take to catalyze integration across the system. When we sat back and took a look at this from the biggest perspective, first off, interestingly, what came to mind immediately was all the things we shouldn't do. And there was a number of them, and we just selected a few, and I suspect the list would even be longer. Number one was, do not provide incremental incentive payments for physicians. Or looking at it differently, don't try to make everything into a $1 transaction and a $3 transaction. You're incrementalizing care. You're not going to achieve what you're looking for. Second is, do not focus on creating additional structures and legal entities. As we've mentioned before, we already have an awful lot of those, and as we go through the presentation, you'll see, arguably, we have too many already, so let's not start with creating more legal structures. We already have a whole bunch of pilot projects underway. Are there ways that we can move away from that? And also, let's acknowledge that this is a big province and that our solutions need to be developed locally.
But there are lots of things that we should do, and we would put forward a few. The first is that you do need at the center to create objectives that are shared across the system, and people need to be accountable. And you know, another way that we put that is everybody's got to have some skin in the game. So everybody's got to have a reason that they need to participate in making integration happen. We do think that there should be some pools of resources that are shared. And again, this comes back to everybody having some skin in the game. Some of the money, if there's not going to be any new money, where's the money going to come from? It's got to come from each of the participating sectors. So everybody's got to have some reason to want to make this a success. But you got to give people some flexibility to shift things around locally to respond to need. So, you know, in other words, participation should not be optional, but how you participate should be up to you. And that's I think, a theme that you're going to see going through. We do want to see local primary care leaders and physicians in particular participating at the regional planning tables. We think it's really important to get docs, primary care docs, engaged in this work, and do ensure that any gains that you make are reinvested back into the system.
Okay, so we have 5 recommendations we're going to walk you through very rapidly. I think that what we'll see on the 5 is that in and of themselves, they're not all that land breaking, but what we're going to try to do is put some examples beside them, because as with many of these things, the devil is in the detail. So we'll start with number 1. Number 1, define provincial goals for improved outcomes. So we were pretty particular in the language that we used here, and I'm just going to highlight a couple of points. We've got some examples of some goals that you could have. We particularly put in the word provincial. We want to capitalize, you know, when we looked at what has been successful in the past, one of the examples that would come to mind, of course, is the wait times program that was put in place in Ontario a number of years ago. One of the elements that's important about that program was that it was absolutely crystal clear from government, this is where we want to go in this province. So we need that stake in the ground, a provincial level goal of where we want the healthcare system to go. We also pluralized goal. We put it as goals. One of the challenges you have if you put a single goal forward is that that's not necessarily going to relate to all the different regions across the province. So if you put forward, and certainly we know we've got more than one issue in our healthcare system, if you put forward 2 or 3 objectives that you'd like to achieve in a year or in a few years, it allows regions to then identify areas of emphasis that make the most sense for them, and then outcome. Now, we were fairly liberal in the interpretation of the word outcome. We wanted to be clinically focused, but we wanted to, it could be a process outcome. One of our concerns would be that if we get too far down the clinical outcome measures, you can get caught in the trap where it requires long-term retrospective analysis to see if you've actually made any kind of impact, and that can diminish the value of your efforts.
So we're going to work through one of these examples, and we picked number 3. So, I mean, imagine that we're working in the same LHIN, Matt and I, and I'm the primary care doc, and he's running the hospital. We take a look at the goals that the government has set, and we say, well, you know, all of these are really interesting, but the one that matters the most to us is reducing the unnecessary emerge visits for CTAS 3, 4, and 5. So patients who are not, you know, particularly sick and whose problem could have been managed in the family doctor's office. So having been given some agency and some choice, we pick that one. And we're gonna start working on that together. So we say, well, we're gonna focus on the high volume users, the people who are in and out of the emergency department relatively frequently. We know that it's an overutilization of hospital resources. We also know that it has an impact, a substantial impact on paramedic services. So ambulance services spend a significant amount of time and money transporting patients to hospital who actually could have been managed in their family doctor's office or their primary care provider's office. For example, in Peel region, 2% of calls annually are related to diabetic emergencies, and some of those obviously could have been avoided. So you're going to take these high volume users, and we're going to try to come up jointly with some priorities that, or with some means of achieving the goal of reducing the number of visits.
Great. Number 2 is create a shared pool of resources. And we've talked about this concept of no new money. And again, going back to the example from the wait times program of a number of years ago, we've also learned that if you even take a small amount of funds, a relatively small amount of funds from the healthcare system and redirect them, you can create a tremendous amount of change. So when we look at how the healthcare system is funded today, you could easily, from a hospital perspective, you could still have my agreement. I have a thing called an HSAW, a Hospital Service Accountability Agreement with the LHIN. That would still be in place, and that would account for, as it does today, about 90% of the funding that I receive at the hospital. You could, however, take a couple percentage points out of there. One of the examples might be our emergency fund, and move that over into this shared pool. Same concept of OHIP billings. You still want to leave the OHIP billings going primarily from the primary care doc through the ministry. It doesn't have to be moved under the LHIN, but are there opportunities to use some incremental funds around that?
And so again, going back to our example, you could take a portion of the hospital emergency department funding and a portion of the existing primary care incentive funds, which are intended to provide incentives for family docs to do certain kinds of behaviors in their practice, and move that into a shared pool of resources. And then you've got some options as to how you want to distribute that fund. One option is you set the targets, and the money gets distributed once the targets are met. Another option is you distribute the money and then you claw it back if the targets aren't met. But the point is that the money is shared. Some of it comes from each of the participants. Participation is not optional, but they get to choose how they're going to do it. And then you measure. And the money is actually linked to accountability for achieving those targets.
Number 3 is establish a criteria for acceptable regional delivery. And this is where we would get in. So if you imagine that we've said the province has set out the objectives, the local area has said here's the one that we're going to focus on. So now let's talk about, from a provider perspective, what we would need to do to apply for those funds. You get into, here's just a little bit of a laundry list of ideas. The key thing for us would be that the way that you would establish this criteria for acceptable regional delivery, the criteria would be set and would be consistent all across the province. There's certain aspects of the delivery group that need to be consistent. How they actually deliver these things is where there can be some variation. So things like making sure it's clear who is the lead organization and the person responsible. Roles and accountabilities of each of the providers involved. Who is the transfer payment agency that is going to manage this for us? What is the proposed use of funds? How are existing structures going to be leveraged? And what is the involvement of patients? And this was one of the things that we also felt is something very important if we think about these integration agendas, is how do we get patients involved in the definition of the service or the delivery mechanism?
So, there are lots of ways to put in place a governance system that could work for something like this, but the point is that you would have some combination of contracts and memoranda of understanding that you would use to ensure that the accountability mechanisms are there. You would want to put in place a local governance committee with participation from all of the involved parties to try to work this out. And this is something that we talked a fair bit about. The democracy matters. As we transfer more power into the LHINs in this province, it's going to be really important to remember that these are bodies whose leadership is appointed, and we need to get community. If we're going to integrate with the community's got to be involved in a meaningful way. And so, actual democracy and also the community perception of democracy is really important when you're putting together committees that are going to be working on this level of integration. Patient participation, worker participation, all of these things are going to be really critical to success.
Just before we leave that slide, just one additional comment is that it looks all very nice and organized, and one of the things that we've alluded to earlier, and Danielle alluded to when she was talking about the number of primary care players, is that line across the bottom with 3 providers being shown there. Our big challenge is going to be that number is going to be a whole lot more than 3. And how do we make that sort of work its way through in this? I think the top part is actually quite clear and has an established process around it, ministry to LHIN, LHIN to transfer payment agency. The key is going to be how that transfer payment agency and the interaction of that group sort of below that level. Number 4 is basically allow the regions then to deliver these services and to define what they would look like on a regional basis. Clearly, when you take a question like the CTAS 3, 4, and 5, there's going to be multiple different ways that you would be able to go about impacting that. But what would work in Toronto would not necessarily be how you would do it out in the Central West Lynn, and certainly would not necessarily be the way that you would do it up in the Northwest. So allow some variation on how that would work.
So just to give you an example of the kinds of creative solutions that we think people might come up with locally, and again, the point here is not to dictate. The point here is to put the goal out there and then see what groups come up with. But if we wanted to, Matt and I wanted to reduce the rate of CTAS 3, 4, and 5 emergency department visits in our local neighborhood, we could sit down together and agree, well, that this shared pool of resources is going to be directed to have a doctor of the day in my clinic who's doing basically an urgent care clinic. Patients will be informed that it's a walk-in situation for the rostered patients in my practice. They can come in if they have a concern. They're going to be seen the same day, or we get put on advanced access scheduling. They can come in when they need to be seen. We may even put in place a method of directing patients who come to the emergency department and are members of my practice to go back to my practice rather than bringing them into the emergency department in the first place. We might try to, so you deal with the supply side, you deal with the demand side, and again, the resources then get directed to support that kind of creative activity, and you measure. And this is the other thing that's going to be difficult, right? Sometimes it's going to work and sometimes it won't. And so we all have to sort of agree going into this that failure is okay, that the important thing is to put the goals out there, and then to try to figure out what's going to work locally, and to give communities some freedom to figure out what does and also conversely what doesn't work to achieve those goals.
And really, Danielle's segued right into our final recommendation. The ability to monitor progress locally and provincially, and probably at the provincial level it may be easier. And again, this is why we picked the example of the CTAS 3, 4, and 5 ED visits. In that these are things that are measured today. We don't have to create new measurement systems to figure out what's happening with them. Certainly in any of these kind of measurement scenarios, you can get into a place where people may try to game the system, may try to find shortcuts that are only designed to change your measurement. That goes back to how are you monitoring progress and what is the role of the LIN and the Transfer Payment Agency in ensuring that what you're really doing is trying to change the way the system is being delivered and achieve the importance of the goal.
So it may be actually that you have different metrics provincially and locally. The province might say, our interest is in reducing emergency department wait times, period, and we don't really, care so much about the details. But locally, we might say, well, we have a growing seniors population in our community. So we're going to work with the CCAC, and we're going to work with the ambulance service, and we're going to work with the hospital and all the family docs in the community, and try to keep those people who are 65 and older, who are complex, out of the emergency department unless they truly have an emergency. And therefore, the metrics that we choose to report locally are going to relate to that particular goal. And we're going to measure more than the province needs to know in order to measure our success on those local objectives.
So, how can Ontario better integrate primary care into its local healthcare system? We believe that there are ways to do it. We believe that you're able to do this without necessarily disrupting the overall flow of the system. It is a bit of incremental because we would do it off of programmed outcomes. You can end up with multiple initiatives, which will become a bit of a challenge for us. But certainly, we think that if you follow the steps, largely steps that have already been defined through some of the change initiatives that have already been tried here in the province of Ontario, you can move this thing forward. I don't know if you can see that clearly back there. We do want to just acknowledge the elephant in the room when we talk about this topic. And in fact, with this topic, it's probably an entire herd of elephants related to this, because certainly as soon as you get into money and funding and keeping or reinvesting into the system and all those kinds of things, there's a million of them. The main elephant that we wanted to come back to was this issue of how many provider agencies we have in the province of Ontario. This is a challenge for us. We are going down a path that is not the way that the other provinces have, where they've moved to an aggressive regionalization model. We are doing it in Ontario through a LIN model that then allows all of us, provider agencies, people, to maintain our autonomy. This is a challenge. How do you integrate a system when, if you add all of the doctor structures that have been described, plus 100 plus hospital corporations, 14 CCACs, hundreds of community agencies, suddenly you're up into multiple thousands of agencies that you are now trying to coordinate into an integrated system without impacting their autonomy of decision making. So that's hard to do. That's the elephant when we try to address the kinds of questions that we're focused on here today. We have not gone back to say, you've got to scrap that and start with the kind of regionalization model that we've seen in other provinces. And admittedly, when we look at that, that would set us back several years as we fight out who's going to be, how does that model sort of work. So we think we found a happy medium here, a medium where we can use our existing structures, we can use LINs. We didn't talk too much about Health Quality Ontario, but certainly that would be a group that the province would rely on to help set these targets. So using Health Quality Ontario, using LINs, using ECFA, using lessons from successful programs in the past in Ontario, we believe you can find a way forward and actually get primary care integrated into the healthcare system. Danielle, any last word?
No, I think that's the last word. Now we want to move to some discussion.
Thanks very much.
Thank you. Yes, of course.
Here, we'll share.
What is CTAS 3, 4, 5?
Thank you. It's a measure of acuity of the patients who are seen in emergency departments. If you've ever been to an emergency department, the triage nurse is the first person to assess a patient, and she or he determines how acutely ill the patient is. So somebody who's really sick would be a 1 or a 2. Once you get into 3, 4, and 5, those are people who, might have a cough and a fever or a twisted ankle. So what we're really referring to is people who have significant concerns that need to be addressed, but don't necessarily require the resources of a hospital emergency department to deal with the issue.
What do the initials stand for?
Canadian
Triage
assessment, is it system? Acuity scale, thank you.
If one of you can take this mic, and then the other one can hold the mic.
Yeah, sure.
And we
I can do that.
To the active question. There we go. And it is Matt Morgan. He's ready with that question.
Yeah,
okay?
that's right. She said it though, right?
Did you guys rehearse this?
Thanks so much. It was a great presentation to hear both of you working together. And Matt, I just reflect that we've created a bit of a mess over the last 20 years from a people, process, and technology perspective. The question I have from a family physician perspective, in terms of the recommendations, they make a lot of sense. Do you think it's fair for the citizens of Ontario, or even the Minister of Health, to say to the family physicians that a prerequisite to considering your recommendations is actually you have to provide service to your patients for at least 12 hours a day, 7 days a week, at no extra cost?
You'd have to have pretty big groups to make that sustainable, right? So, the short answer to your question is no. It's not fair to say, given that we have set up a system in which a family doctor is completely within his or her rights to set up a single provider fee-for-service practice, it's not fair to say to somebody you have to work 12 hours a day, 7 days a week in order to practice medicine in the province of Ontario. There's a history to how medicine has been set up in the province, so we can't simply wake up one day and say, we've decided to change all of the rules. However, I do think what we've seen over the last 5 years is that if you put structures in place that push people into teams, you can expect that there will be increased access for patients and without making life unlivable for healthcare providers. So, we all read the Auditor General's report around the success or spottiness of the success of these models, and I don't think that we've maximized at all what can be done with the existing models. We've got most family doctors into teams now, and we've got most of them off of fee-for-service. And we've also seen family doctors get a quite substantial raise in our earnings over the last 5 years, which I think many would argue was long overdue. So we're well paid, we're organized in teams, and we don't have to pump people through on an assembly line to make money. Those are the preconditions to getting to the state that you're talking about. And you could begin simply, as we have, by saying, you know, at the very least, you got to be open until 8 o'clock at night on the weekdays. At the very least, you got to be open, you know, for a few hours on Saturdays. And now that we've put those preconditions out there, we have to actually tell patients that we're open during those hours, because a lot of them don't know that is available. We have to have appointments open every day on a same-day basis. And we have to think really hard about what incentives we can provide for patients to use those services instead of going to the walk-in clinic or the emergency department, and what incentives we can provide the emergency department and the walk-in clinic to push those patients back to their family doctor. Because I got to tell you, as a family doc, you know, my night is Wednesday night. I'm there till 8 p.m. and sometimes there's nobody to be seen. And it's not because none of the 10,000 patients in our practice are sick that night. It's because it's, you know, easier, more convenient to go down the street to the walk-in clinic with your baby who's got a fever than to put them in the car and schlep them all the way to women's college. I understand that, but then we've got a system that's working at cross purposes to itself. So it's a broader issue, and no, I don't think that simply declaring from on high, thou shalt be open 12 hours a day is going to be sufficient for dealing with all of it.
Can I just add a comment?
Yeah.
I just want to add a comment from a hospital perspective. I liked pretty much all of the comments that Danielle just made. I would add the other thing that I would like to see is that in the context of what Danielle has just described, we put up as one of our early dues is involve primary care and doctors in the governance and decision-making process. And one of the things that we're just taking some baby steps on up in the central West Lynn today, and there's probably other regions who are doing this already, is how do we re-engage primary care in the decision-making around resource allocation of healthcare services in their region. And part of that is a quid pro quo of, so here's the things that we're able to do here as a hospital, the big hospital up there, and what services we can provide. Here's what we need from you, so that we can actually make this more seamless. Because part of this, just going to Danielle's example, it may not be, we may be fine if they didn't open on Saturday, because we're cool. Saturday is not a bad day for us, I'm just using that as an example. However, Sunday is a real big problem, and Family Day is a really big problem, and Boxing Day is a really big problem. And so inside a hospital, you know, and Matt, you would know, on Family Day and Boxing Day, nobody really wants to work those days, but somebody has to be working, and the hospital has to make sure there is coverage on those days. Think of that same model at a regional level, where we would say, okay, so on Family Day, is there anything going to be open besides the hospital? And how are we going to manage that and make that work? Because having extra people open just before Christmas may actually not have all that great of an effect on the things that we need to try to achieve for the province.
Right, and if we were sitting around the Lynn table having this conversation, which, you know, amazingly nobody seems to be having yet, but it's going to come, right? You would say that, and I would say I totally agree. And the other thing is, if I'm seeing patients in an urgent care setting, and somebody walks in who's really sick, and I spend the time assessing that person, I want to be able to pick up the phone and call the specialist in the hospital and say, I'm sending in this patient with a possible appendicitis for assessment by the general surgeon. Not, I have to send the person to emergency to then be reassessed by the emergency doctor, to sit and wait for 8 hours in the emerge so that the emerge physician can then call general surgery. So, you know, it's all going to cut, you know, in all ways. And once we start to have those conversations, then we can begin to meet each other's needs.
So Ross Baker liked that answer, but he's also got a question.
So thanks for a great presentation. You know, I think this issue about pilot projects is an important issue, and you mentioned the sort of Canadian disease, which is that we spread all these pilot projects and we get a few nice little flowers and then nothing happens. So the issue is not that pilot projects aren't a good thing, because we have to figure out what works in local context, and Matt, you said that. The issue is, how do we take what works and spread it and sustain it across a broad, diverse system? So, you know, planting a few seeds in Brampton or downtown Toronto is not the answer to primary care integration. How do we now create a structure and some processes that allow us to take this problem and then work with it across the province with people who are not so interested right now in working on it, as well as the people who are?
So we may have different answers to that question. It's my own view that participation in integration is not optional. So that is the first precondition. And so you set up the governance structures, you put the goals out there, and those are not negotiable. If you want to be practicing medicine, if you want to be running a hospital, you have to be participating. And then the very important component of local choice falls underneath that umbrella. I think that there is a very cogent argument to be made that you should start where the low-hanging fruit is and just start with the FITs, right? Bring the FITs into the LHINs. The FITs already have the structures. They've got executive directors. They've got the funding model. Start with the family health teams, see how it goes, adjust, learn. It's my view that the time for that is over, and that actually what we need is a system-wide change, and you just have to grit your teeth and bring in every single healthcare provider in the community all at once. But I think that there is lots of room for legitimate debate on that.
I would go sort of in the same direction as Danielle with maybe a few variations. First is that the idea of just publishing success stories and hoping that others will pick them up, I think we've kind of proven that's not going to work. I can say that my email, I'm on a whole bunch of knowledge sharing networks of various descriptions, and the fact is that I don't have time to read any of them. So it's just, they pop up and I just don't get to them. I like the idea that Danielle's talking about making sure that things become a little more mandatory. One of the things we don't plan for when we plan these pilots is plan for success. So what happens if the pilot is a success? We tend to wait until we find out if the pilot's a success to determine if we're going to do anything. So, one suggestion might be that when we're calling these things, and so we don't have a problem, sorry, me. I have a problem with the term pilot. I don't have a problem with the idea that someone has to go first, right? So you might want to go first and figure out, did we get it all, organized correctly? But I can tell you, just as a person in the healthcare system, if somebody's doing a pilot and it may or may not have any impact on me, then I may or may not pay attention to it. If I know that the outcome of that is going to have an impact on where I'm going to be going, I'm going to be paying an awful lot more attention as to what's happening there. So I think that as we approve pilots, as we approve first steps, there's a level of discipline that needs to be added that says, we're doing this because we intend for this to be a success. And a success means that this will then roll out in the following fashion and not leave it up to figuring that out once the pilot is either successful or not successful. So sort of a spin on that idea of you've got to make these things mandatory, otherwise they will just stay as a bunch of nice flowers.
We had someone on this side. Who was it? There we go. Tell us who you are.
Hi, Matt. It's David Kaplan. I'm not the minister, ex-minister of health. I'm the primary care lead for the Central Inn and a family physician as well. Matt and Danielle, wonderful presentation. Obviously, it's a lot of the work that the primary care leads have been in charge to do across the province. One of the issues, and you talked just briefly about it now, about sort of things being mandatory. Right now we have a lot of family physicians that have disengaged from acute care hospitals, so we don't even have a way to touch them because they're not on staff, even courtesy staff at a hospital. What are your thoughts about that around integration? Because I was the interim chief at North York General for 2 years, and we have probably one of the largest departments of family medicine. It's about 370 family physicians on staff. There's probably another 400 in the catchment area that aren't on staff, and we have really no way other than now getting their fax number to interact with them.
Yeah. Well, maybe I'll make a couple comments and then hand it over to Danielle. I'll just go on actually as a spin on the point that I made about our little pilot project. So first off, we have a lot of work to do in re-engaging with primary care. For a whole bunch of reasons of which you guys probably know better than I, there's been this growing divide between the hospitals and primary care, and I see it up where I am today. I think that we have to do a few things. One is get primary care back engaged in the decision making, even if it's on an advisory capacity. We have to recognize that the board of the hospital will always be the ultimate decision maker, as long as there's still a board, on how resources will be used in the hospital. But how do we get primary care engaged at that level of discussion around, what are going to be our major projects, where are the places that we're going to put our emphasis, what programs are we going to be opening, all that kind of stuff. What I've also found is that if they come in and give us some of that advice, and if they see that we're taking some of that advice, engaging them is not that big of a problem. They stay in tune. The other thing that we're looking at right now at Osler is the legislation recently came through that we can't have doctors as voting members of our hospital board. Fortunately, we have a pretty good relationship with our medical staff, so that didn't prove to be a huge problem for us, although it was still a little bit of a slap. So now we're looking at, can we get doctors who aren't engaged, formally credentialed at Osler, to be on our board, to try to get that connection back to doctors playing a role in decision making on the resources within the hospital. I would say the biggest challenge that we've faced so far, which I did mention tangentially in the case example, is that this is easier to do in Brampton than in Etobicoke, simply because of the relative one-to-one relationship that we have with that facility to our primary care group, as compared to in Etobicoke, where we go out to that, our primary care group, and they have an equal or even perhaps lesser relationship to Etobicoke General than they would have to some of the other hospitals in the area. And now it becomes a problem for the family doc, is they're now trying to deal with 4 or 5 different hospitals just in their catchment area.
So I was wondering if we were going to make it to 9 o'clock without my saying something that can hurt my future career, but at 8:59 I'm about to do it. Drummond was pretty clear that there are 2 options for integration. One is to do it through the hospitals, and we all know that the hospitals in Ontario have got the resources, they've got the smart people on their boards who are connected to Bay Street. They've got the CEOs who are really understand how to run a healthcare system. They've got and are brilliant the CEOs, and all of that stuff. And option 2 is to run integration through the LHINs, which have been under-resourced, haven't had the leadership capacity, haven't had the teeth. Haven't really been able to cut their teeth in doing any, they've been sort of, I have huge respect for the LHINs, but it's not like Alberta Health Services, okay? It's a different situation. And I am of the view that although the capacity at the LHINs right now is questionable for taking on integration of the entire system, shoot me now, although the capacity is questionable, it's the only way that you will get primary care and community care engaged. Because you cannot ask the family docs who've been forced out of the hospitals, who've been, who feel neglected and undervalued, who feel like their specialist colleagues don't care what they have to say, who feel like the hospital isn't responsive to the needs of their patients, to then come into the hospital to talk about how services are going to be integrated. It has to be run by a third party, and so it's got to actually be the LHINs, in my view. And I don't actually think, for all the smart people in the hospitals in Ontario, that the people who run the hospitals know anything about community care and primary care, sorry. And so...
We were this close.
We were so close. I told you, 8:59, it had to happen, right? So it has to be done by an impartial third party. And the LHIN is actually in a good position, because what the LHIN does is the LHIN says, please come hospital, please come primary care person, please come CCAC, please come union, please come all the players. Let's all sit down together, nobody more equal than anybody else, and let's figure out how to do this together. And I actually think that is what's exciting, and you got to go with the train that's leaving the station, and that's the opportunity that we have here, is to use the LHINs to that effect.
So Danielle, we started 1 minute late, so I'm going to take one more question here. Would you identify yourself, please?
Hi, my name is Dev. I'm the director with Cancer Care Ontario. Just a quick question. I know it's not really a quick question, but how would you anticipate that democracy would work in practical operational terms in connection with the new governance model?
Yeah, that was your comment, baby.
It was my comment. So I don't want to dodge I don't want to seem to be dodging the question, but I don't think you can design the process from on high. So the first thing you have to actually do is to bite the bullet and go out to the groups, and we all know who they are, who feel that the LHINs are undemocratic, and ask them, how could we do better, right? So, you know, go to those, go to the community, go to the unions, go to the health coalitions, go to the physicians and say to them, you know, I'm talking about the physicians out in the community, and say, you know, those of you who have had concerns about the LHINs being undemocratic, given that the LHINs are what they are and we need to move forward with integration, what are the mechanisms that we could use to involve you? And of course, you know, it's about putting people onto committees. Of course, it's about having community meetings. Of course, it's about doing outreach. Like, there are lots of implementation mechanisms for that. But, you know, if you design it without bringing those people in to help you design it, then you're just sort of reinforcing the problem, I think.
Yeah. I don't have too much to add to that. I would add that some hospital CEOs do know about community services, particularly if they were formerly LHIN CEOs. And not only are they quite smart, they're also quite tall. I would say I couldn't agree more on many of the comments in terms of the role that the LHIN plays. I would challenge, and you know, Danielle is a doc and I'm not, I would challenge that the docs will find more affinity to a LHIN than to a hospital. I think that might vary. We may find that varying a little bit across the province because of some of the challenges that the LHIN brand has had in moving some of this stuff forward. I do think as well, though, the concept, I just think overall, both when I was at the LHIN and now that I'm at a hospital, we have not been properly engaging physicians, primary care physicians, in the resource decisions going on in their region. Now, whether we want to make those changes at the LHIN table or at the hospital table, my advice would be to do it at both places because you're talking, in many ways, you're talking about two different levels of decision making, right? At the LHIN, you're by design, you're talking about overall structures that are going on within that region. At a hospital, you're talking about what's going on the ground, what shifts are being put forward, what services are being put forward. So I think that there's opportunity to work at both of those levels if we really want to make this thing work. And one of our comments back on the do was involve primary care docs in the decision making, because right now they've been pushed out and it's very hard. And going back to the question that started here from Matt and the response, if we just go back to primary care, the absolute don't is just don't go back to them and say, now you've got to work 12 hours, see you later. That you can expect a pretty poor response if they're not being brought to the table and asked to contribute to that decision making in a meaningful way.
I might add that Dr. Barry McClellan, who has had some discussions about these topics with these two speakers, also wants to come to Breakfast with the Chief yet this year. So we'll make sure that he watches this particular program and adds to it. Before you thank our speakers, I do want to acknowledge that Accenture has been a sponsor today, so has Baxter been a sponsor today. Relay Health, which is part of McKesson, has been a sponsor today, and Strata Health, who is here with a team, has been a sponsor today, and that's why you're not paying for these events. So please show your appreciation for them. And Danielle, you are welcome back anytime.
Thanks, Anton.
Thank you for coming to Breakfast with the Chiefs. Your speakers.